For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up, Season 3, Episode 63, our final set of year-end wrap-up interviews for 2022, starts now.
Today, on Surfing the NASH Tsunami.
The reality is that when you look at patients with type 2 diabetes, where the prevalence of NAFLD is 60%, we're probably seeing 5% of them. If we go from 5% to 20%, we made a huge impact and we prevented a few patients from progressing to cirrhosis and its complications.
When looking back on 2022, I would say probably the most incremental advances in the field of NASH in the past decade. It's going to be hard to beat 2022 and 2023.
We have to make the pathways as straightforward and easy to use as possible, regardless of liver disease, and ideally using the same pathway and the same tests to identify those patients who would be suitable potentially for a specific therapy or other intervention that can be provided.
As an exciting 2022 comes to an end, Surfing the NASH Tsunami looks back on some of the year's key advances. Join hepatology researcher and key opinion leader Professor Jörn Schattenberg, liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and our guests, hepatology researchers and key opinion leaders Drs. Naim Alkhouri and Harrison and Professor Ian Rowe, as they consider the year's key gains in knowledge, commercialization, and advocacy on this special year-end edition of Surfing the NASH Tsunami.
Hi, it's Roger Green. Welcome to our third and final round of 2022 wrap-up interviews. The format's the same one we initiated in 2020 and used again last year and earlier this year. This episode will include sections of interviews with three of the people who made headlines and advances in fatty liver disease in 2022. Each conversation, released Friday or over the weekend, will provide one of those interviews in full. This episode includes three of our favorite guests, people with extremely diverse perspectives. Naim Alkhouri discusses some of the reasons he considers 2022 such a promising year for fatty liver disease, focusing not only on drug and diagnostic discovery and research, but also supportive digital apps and the need to address pediatric and adolescent NAFLD more seriously. In an interview conducted before the Maestro NASH data release, Harrison discusses the steps we will have to take to have NITs recognized as appropriate endpoint measures in clinical trials, and then looks at the next few years of advances in drug development. More important, approvals. Finally, Ian Rowe discusses what is happening on the ground in the UK today in terms of bringing primary care into screening and diagnostic protocols, and over time perhaps into treatment, and also expresses his enthusiasm for the recent advances in NIT and drug development. Louise, Jörn, and I had fun conducting these interviews. Have fun listening. By the way, there will be no business report today. Instead, Grace will be back after these discussions with a brief description of our first week of 2023. And with that, for the last time in 2022, I'm off. Thanks to the crew, Jake and Magic Mike, who wound up working with me through the last week of this year to get out all these episodes and conversations, and Eric and Steve for all you do. Until our first episode in 2023 next Wednesday, stay safe, surf on. We'll see you in the new year on the podcast. Bye-bye now.
It's been a very productive, positive year for NASH. Started with the approval of the ELF test beginning of the year, so this is FDA approved now in the United States, and it's been approved in the UK for a while, but now we can actually run the ELF test through commercial labs, and this has been a very helpful test in our clinics. The scenario has been that about 60% of patients we see in our clinics, we can rule out advanced disease just by doing FIB4 and a FibroScan. We have typically about 10% where we can actually diagnose advanced disease, even cirrhosis, just looking at platelet count and imaging and FIB4 FibroScan with the high KPA. But about 40% we were in that indeterminate zone that we really needed another test. We've been doing other tests that are also very helpful, such as MR elastography and corrected T1, but they're not as widely available as the ELF test. So having ELF commercially available has made an impact in our clinics. So I use it in cases where the tests are discordant or I'm stuck in that indeterminate zone to help me risk stratify my patients. This year we witnessed also the implementation of these algorithms by the American Gastro Association and the American Association for Clinical Endocrinology that utilize the sequential testing and primary care endocrine. We presented data at the ASLD liver meeting looking at the implementation of these algorithms on the United States population level, showing that by doing this, only about 8 to 11% of patients at risk for NAFLD and its complications will need to be seen by a specialist, a hepatologist, gastroenterologist. We also seen a few abstracts, publications on new scores to help us identify patients with at-risk NASH, defined as NASH with NAFLD activity score 4 or higher and F2 fibrosis or higher. So we've seen abstracts on MiFib, which includes FIB4 and MR elastography, and then our score, the MAST score, which includes MR elastography, MRI PDFF, and AST. We also have seen a sneak peek on the ASLD guidance document, and I was very happy to see that in addition to the primary care pathway, they have a specialist pathway to help us identify at-risk patients utilizing things like the FAST score, MAST, and MiFib, and CT1. In terms of therapeutics also, I think 2020 was a little bit, slow year for us. 2019 was disappointing. I think 2022 was a good year because we had a few what I call jaw-dropping moments at the ASLD liver meeting. I was very impressed with the Akira data showing NASH resolution 76% after 24 weeks of treatment. Everyone has been talking about this, but not only that, fibrosis regression, improvement in the majority of NITs, and again, short duration, okay tolerability, so this is exciting. I was impressed also with the Ultimmune data, very short, 12 weeks, patients were treated with pemvidutide. What was very impressive for me was that about 95% achieved that 30% relative reduction in MRI PDFF, hepatic fat fraction, but also the fact that about 55% actually reduced liver fat less than 5%, so you cannot even call it fatty liver anymore. So that was very interesting and got me thinking about the possibility for curing this disease, not just improving fibrosis by one stage or decreasing the NAFLD activity score, but really getting to a cure, and about the concepts of induction therapy, intermittent therapy. So maybe NASH will look different than type 2 diabetes, and maybe people don't have to be treated for the rest of their lives. I don't think this is going to be the majority of patients, but I think in younger patients without advanced fibrosis, we may get to a point where we say there's no more disease to talk about. We'll monitor you on a yearly basis, and if we see any recurrence, maybe we'll go back on medicines, but let's stick with lifestyle intervention. Speaking of lifestyle interventions, we completed 2 studies this year, one with Noom. I will probably discuss these in more details, but Noom is an app that's available. You can purchase it. And then we completed another one with a company called Better Therapeutics, and there was a press release about a week ago. This is a little bit different than Noom because it's a prescription digital therapeutic. But the idea for both is that providing this comprehensive lifestyle intervention, and we will be able to show in abstract forms in the near future some positive findings that we can discuss more on a later date. So I think this is important because we're all limited by our time in clinic, and to have something that the patients can download and have access to an experienced team that can provide counseling, lifestyle intervention is very helpful. And I think it's going to be part of initiation of drugs, but also maintaining the therapeutic effects, and potentially in patients where we can stop drugs to maintain the beneficial effects from the drugs without needing to go back on therapeutic agents. So I think this is a very promising area. So this is my take on the year. I think it was a positive one. I'm happy. It was a nice ending with the World Cup also. This is very unusual for us to be watching World Cup matches close to Christmas. This is the first time ever, and it's been a good one, and we'll see what happens on Sunday.
There are a bunch of places that we could dive in. Let's go back to the 8 to 11% number and the algorithms, which to me, and no one else has mentioned that, but I thought that was really compelling. Right? One of the issues that we've been hearing about forever has been hepatology can't handle the load. But to what degree do you think that the combination of the consistency in the guidelines and pathways that the AGA, ACE, ASLD, et cetera, are putting out with that 8 to 11 number at the back end makes this feel either more doable for the medical community, or do you think there are still challenges in terms of, even if we could get everybody to do the right thing, do we have enough volume in the specialty community to deal with the patients who'll come in?
I think it's more durable, obviously. We estimate that we have probably 90 million people with fatty liver disease in the United States alone, so we cannot have them seen in specialty clinics to risk stratify them. I think FIB4 is the cheapest test we have, so this is widely available. We've been been talking about it, but I think that we standardized now the cut points, we simplified it for primary care physicians, and the fact that when we initially started with the FibroScan as the next step, and it was only FibroScan and the AGA algorithm, I had my concerns that we would not be able to implement this on the United States population level just because of the availability of FibroScan machines. Obviously, there are other ways to measure liver stiffness, including shear wave elastography, and now we have newer machines like the VeloCure machine, and potentially in the near future also the hepatoscope and other, ultrasound-based technologies. I think MR elastography is becoming more available. CT1 is becoming also commercially available outside of clinical trials. But I had my doubts that this is still difficult to implement, because if you go with FIB4, you still have, if you implement it for the at-risk population, you'll end up with about 13 to 15 million people that will still need more testing, which meant initially FibroScan. So I think having the ELF and the algorithm with ASLD is going to make it more feasible. Now, at the end of the day, these are all hypothetical numbers, and the reality is that when you look at patients with type 2 diabetes, where the prevalence of NAFLD is 60%, we're probably seeing 5% of them. I don't think we're going to be able to solve the problem for the entire US or UK population, but I think by implementing this, if we go from 5% to 20%, we made a huge impact, and we prevented a few patients from progressing to cirrhosis and its complications.
Louise, Naim, when you're dealing with Louise, you're dealing with a significant advocate for the benefits of FibroScan above and beyond liver sickness in terms of liver health. I'm going to throw the floor to you guys for a couple of minutes to discuss the implications of going straight to ELF versus going to FibroScan and where each might you feel be appropriate. Louise, I'll let you go first.
I think Naim's absolutely perfectly correct. There isn't enough FibroScan or availability to be able to implement the guidelines by just using FibroScan. So you do have to use multiple different tests. The figures of only needing to see 9 to 11%, again, aren't surprising, because in our practice in the NHS, we would discharge 92% of people sent for abnormal liver function tests once they got to FibroScan. That is an awful lot of time, effort and resources, and that 92% that we send back are blocking the current pathways for the other ones who we do need to see. Within healthcare, certainly in the UK, with the pending approval in the new year and early 2023 of NICE to allow FibroScan access to primary care, will, we hope, reduce that. We will find the right people to get to secondary care and specialists. And what my biggest concern is what do we do with the soft fatty livers without a pathway development sitting in primary care, because they still need to be monitored. Fat in the liver is abnormal and they still need a pathway. So it's how we implement that, and I think we've discussed it previously this week in some of the sessions on. I would like to see more dietetics, more nutritional support, more education into primary care, nursing support when they're looking at diabetic patients, the same cohort that Naim was just mentioning there. So I think there's lots of opportunities. Most poor liver health does not need to see a liver physician, and I think that's what it's saying. So it should be owned by cardiology and endocrinology and metabolic medicine, and only where you get liver disease and fibrosis do we really need to intervene from a speciality service. I've said before, I don't mind who owns the liver from fat and from ill health, as long as the right people get to see the person at the right time to help the person as a whole. Those figures don't surprise me from what we see in routine care. And I suppose from my other side, where we get lots of buy-in from members of the public owning their own liver health and liver healthy lifestyle should be an option. At the moment, the default is to find out you've got disease. And that is driving admissions to hospital, it's driving other diseases, it's reciprocated by other diseases. That's a healthcare situation that we can look to assist on and help, because actually using the liver to help health services and health personnel, we don't have enough doctors and nurses to be able to look at these patients. Even if we did screen the 90 million Americans and got it down to 15, that is still going to overwhelm hepatology resources in the US and any other country. So by doing it in the lifestyle choice and making it's cheaper than going to the gym, just know what the gym's doing for you, or what your dietetics, what your other apps are doing for you. I think we can prevent so many people going into that timeline. We just don't measure it currently, because we don't measure the outcome of Noon on preventing people going to healthcare. We don't measure the outcomes of Fitbit stopping people going into healthcare. So we don't measure those metrics currently in a financial way. Maybe we should be.
Again, a lot to unpack. Between the two of you, we've created enough, and let's littlest 15 minutes, we could spend the next 3 hours unpacking. I think at the intersection of those two thoughts, though, in my mind, is something like this. Naim, first of all, I think you're absolutely right that guidelines, like everything else, get adopted slowly. And here, one of the challenges is that a main path for guidelines getting adopted is money that comes largely, frankly, out of pharmaceutical companies, in the States at least, which is where most of the education of doctors gets done. And admittedly, it's imperfect education. It tilts a little bit towards pharmacology. But in this case, any education about guidelines is better than what we have right now. But Naim's point about going from 5 to 20 would be a significant advance. I think if you could do that in a year or 2 years, that would be heroic. And at the end of all that, Louise, we've got a long way to go to get towards the kind of thing that you're describing. But at least we're on the flight path to get there. If we succeed in getting drugs approved in 23 and 24 and 25, then more money will be there, I think, to make that happen. Naim, so one of the things I've talked about this week in the States thing is the idea that LabCorp will now reflex an ELF test based on a FIB4 result, and that you can hit .FIB4 on Epic and get a number. Makes this a lot easier for for doctors, even in primary care, who are affiliated with hospital systems, to do the right thing, if appropriately educated. Where do you feel we're at right now in terms of getting people educated on what to do?
Yeah, this is a positive development. I think it simplifies the testing for primary care physicians, endocrinologists. This is similar to what we did with hepatitis C, where you do the hep C antibody, and then if it's positive, you reflex to HCV RNA. And it just simplified things, because we used to get these patients that are coming with the antibody, then we had to order the RNA, and then it's negative, and then it's like, oh, don't worry about it. Having the all testing done by the time they come to see us will help us make decisions faster. So the idea here is that you do the FIB4 when you have a CBC and a liver panel, and you have your AST, ALT, platelet counts, you have the patient age, and then if the FIB4 is more than 1.3, then you reflex to ELF. I think the biggest challenge has been the way the ELF was approved in the United States as a prognostic biomarker, and the way the reports are, coming back to primary care physicians. So we know from previous papers that ELF less than 7.7, that indicates typically F0, F1, no significant fibrosis. So in my mind, and if you look at the guidance documents, less than 7.7 is where you keep patients in primary care and you just focus on lifestyle intervention. But because it was approved as a biomarker for progression to cirrhosis and complications, now 9.8 is the cut point that is being reported back. So if you're less than 9.8, they say you are at low risk. That means you're low risk of progression to cirrhosis or actually developing complications like ascites or variceal bleeding. Doesn't mean that you're low risk for significant fibrosis. So now, you have a primary care physician seeing a test that's saying lower risk, but it could be 9.5, which is, in my mind, F2, potentially F3 in some patients. They're telling patients, oh, you're good, don't worry about it. So this is creating some issues. I think we need to educate more. The problem is, as you said, the education comes usually from the diagnostic companies, pharma companies, but when they have an FDA label, they have to stick by that. So I don't think Siemens can go out and tell people 7.7 is what you need to do. So we need to utilize the guidance document and have them to fund more like CME activities, non-pharma, non-diagnostic sponsored activities for primary care physicians to actually get that education and tell them how we utilize ELF. But to simplify, for the audience, I guess, less than 7.7, F0, F1, 7.7 to 9.8 is typically your F2, 9.8 to 11.3 is F3, and then more than 11.3 is F4. This is also simplified. ELF has issues, but I think this is the education that I would like to see out there. This is consistent with the guidelines also, but I just wanted to highlight this issue. But at the end of the day, as you said, Roger, I think, doing the reflex to ELF is really a good idea, and I think it will help us. But again, we need to educate on how to interpret the results.
That's an excellent point. I'm mindful of the fact that one of the things that really turned cholesterol around now 30, 35 years ago, I show my age when I do things like this, is when the reference labs stopped highlighting cholesterol that were 2 standard deviations above the mean for the U.S. population, and instead simply picked a level and said, above this level, you got to think about it. Appreciating what you say about the labeling on ELF, I'm wondering if the guidelines give the reference labs an opportunity when reporting the result to asterisk anything between 7.7 and 9.8 and say, guidelines from so-and-so and so-and-so say that at this level, patient might have significant fibrosis. I don't know if that's a doable thing. I've not interviewed a reference lab about that.
Yeah, it's a conversation that I think we should try to have with LabCorp. And, now Quest is also doing ELF.
Naim, can I just ask, if we step that back a little bit, the majority of the world still don't do a standard blood profile for AST, ALT and liver function. to be able to comply with FIB4. Do you think that's arguably the biggest change that has to happen globally, is that we have to say that every single time a blood profile is done routinely around the world, just as a minimum for liver disease, that we now have to standardise and say we should be able to calculate a FIB4 across the world in every country, and it shouldn't necessarily be for the payer to add just the one test? Would that make a huge difference to that early detection of more advanced fibrosis, do you think? And is that achievable, is the second one?
It's a tricky one because FIB4 has also its own issues, so I worry about making it standard with every time you do a CMP CBC that you get a FIB4, and next thing you have the 20-year-old who's having the flu, and for some reason their platelet count is a little bit lower than usual, and then now you're telling them, I don't know what's going on. I mean, your BMI is at 23, you're healthy, but somehow your FIB4 is high. You may have fibrosis. You need to see a specialist, or, let's do a FibroScan or an ELF test. I think it's a great idea in patients with type 2 diabetes, for example. They are at risk. I think it should be a no-brainer. You can even argue to do it in obesity. I think when you do things like this, then the limitations of FIB4 should be talked about more. Now, we're saying, okay, if you have diabetes, metabolic syndrome, elevated ALT, you're already at risk for NAFLD, then do FIB4. And fine, we're not going to complicate it for you. So 1.3, 2.67, this is all you need to worry about. If you're going to tell me on a global scale now we're going to calculate FIB4, then I need to talk about the fact that it doesn't work in children, the fact that it doesn't work even in young adults as good as we want it to. We have to talk about the elderly population. We have to also educate that if you have other things that can affect your platelet count, from ITP to whatever medication you're taking that may lower your platelet count, to a viral illness, that take it with a grain of salt, maybe repeat it. So it has to be implemented differently. One way to overcome this in terms of an acute illness is maybe to say, if it's slow and no other risk factors, maybe repeat in 3 months, or something like that. That might be one way. But I feel like what we have now is good in the context that we are trying to implement it. Everything will come with issues. I don't think it's not a good idea. It's just how you implement it and the kind of quality assurance that has to come with it. We have to think it through and just do it in a way that does not create issues and kind of medicalize some people that are fine. And now they're going to be told that maybe you're at risk for having, liver fibrosis.
Oh, yeah, totally agree. And I think there's enough caveats. This is worth looking at unless there's another reason for this FIB4 to be elevated within this category. That can be easily done, and it's not perfect, but it's better than we've previously had, given the lack of ability of blood biomarkers to really tell us much. Nothing's perfect, as you say.
There have been a lot of pleasant surprises in the field of NASH in 2022. I can think of at least 5 out of 6 press releases that were very, very positive. Every phase 2 trial that reported hit their primary endpoint, and the number of companies jumping into the NASH space didn't go down. It actually went up. And now there are more big pharma companies in the space. And I think that's incredibly positive for the field. So just from a drug development perspective, 2022 was a good year. Of course, it's December 15th, and we are waiting anxiously for the Madrigal data, which would be the icing on the cake if that came out positive. And I'm very hopeful that will be the case. I think we all are hopeful that will be the case. It was good news to see that Intercept is refiling, and they have a ton more safety data to go along with very similar efficacy data from before using a separate methodology. And so that was encouraging. I think we made huge advances in our methodology of interpreting liver biopsies in 2022. While we still have issues related to the liver biopsy itself, I think we've gotten better at understanding its limitations and how we can mitigate that to some degree. I think we made huge advances in AI digital pathology and how that could potentially augment current histopathology reading. Look, just recently coming out of the Mosaic conference that happened a week ago, Monday, Tuesday at the French Embassy in Washington, just amazing meeting where we had multiple divisions of the FDA represented, multiple stakeholders across the entire metabolic syndrome, from cardiologists to nephrologists, endocrinologists, hepatologists, radiologists, biostatisticians, editors of the 3 leading journals, New England Journal, Nature Medicine, and Lancet, all present. There was a significant amount of interest in looking at developing clinical trials that tackle multi-organ system disease and get at multiple different endpoints, number one. Number two, very insightful information about the development of non-invasive tests to supplant liver biopsy. And here's a little teaser for NASH-TAG 2023. We're going to have a deep dive discussion on that conversation that came out of Mosaic at the Fireside Chat on Saturday night in Deer Valley. Coming out of that meeting, we should have relatively clear goals for how we can relatively quickly move to a non-invasive as a surrogate endpoint for Subpart H approval. So when looking back on 2022, I would say probably the most incremental advances in the field of NASH in the past decade. It's going to be hard to beat 2022 and 2023, but knowing how we're setting up the year, it's entirely possible that next year will be even better than this year.
It's interesting to listen to you say that, because when I go back over the year month by month, it started on a real high in NASH-TAG. There were 2 hiccups over the course of the year, and it's really closing with a bang, right? I mean, aldafermin was a bit of a hiccup, and that was like, April maybe? And then there was some perception coming out of Paris and Dublin that regulators might not be moving as quickly as folks had hoped they would be moving. I think in the scheme of things, the reaction to aldafermin turns out to have been overplayed based on what we've seen in some of the trials later in the year. And I'm going to ask you about the regulatory, because I'm assuming that when you talk about Mosaic and the deep dive, that's really where you're going.
Let me say this about aldafermin. Aldafermin's a good drug. I think aldafermin absolutely works in NASH and on fibrosis. I just think the study design did not lend itself to allowing that drug to show its real capability. And it's just a shame that that's not currently being developed. But I would say that maybe that story is yet to be fully told. On the non-invasive testing front, I think we have to separate the biomarker qualification program from the Division of Hepatology and Nutrition that approves drugs and claims for liver disease. And perhaps that might be some of the disconnect between what came out of Paris NASH and Dublin and what we're hearing from Mosaic. And we'll tease apart that a bit at NASH-TAG, but the biomarker, the CDRH and the biomarker qualification program is a very rigorous program, just like developing a drug for any disease is a very rigorous program. But if you look at the 2018 draft guidance published by the FDA on drug development in NASH, there is the ability to use surrogate endpoints that are reasonably likely to predict clinical benefit, not validated surrogate endpoints. So there's 2 different ways of looking at this, that you can have a validated surrogate endpoint and you can have a reasonable surrogate endpoint that could have a reasonable chance of predicting clinical benefit. So the way that I interpret what's coming out of the personnel that work at the FDA is if we can show data that is a surrogate endpoint, so a non-invasive test, in this case, not a liver biopsy, that's also a surrogate endpoint. But let's just look at non-invasive tests. And I'll use MRI-PDFF as an example. If we could show that MRI-PDFF change with drug treatment has a reasonable likelihood of predicting clinical benefit, then that could be used as a Subpart H approvable endpoint, with the caveat that you would have to go on and show that it actually did lead to long-term benefits. So we have data already present with multiple biomarkers, whether it's FIB4, FibroScan, MR elastography, ELF score, CT1, AST to some degree, but really it's ALT that has the 17 unit per liter drop. All of those have shown, maybe with the exception of ALT, all of those have been linked to outcome benefits. So ELF has, FibroScan has, MRE has, and CT1 has. MRI-PDFF has not yet either. But the way I look at this is, and we have to mine the data a bit more. This is why we're doing Litmus and Nimble and NAIL NIT and Goldmine. But if we can show that these NITs are moving the needle relative to histopathology, and I mean NASH resolution and or fibrosis improvement or both, then I think that we've already established that NASH resolution and fibrosis benefit are reasonably likely to predict clinical benefit and have been approved as a surrogate endpoint in Subpart H. If we can show that these NITs are doing the same thing, then I think we have a compelling story to take to the FDA and propose this. Now, their job is not to inform clinicians about clinical data. It's clinicians' job to inform the FDA about clinical data. One of the areas that it struck me at Mosaic that we have not done a good job, and I'll say that I haven't done a good job in doing, is synthesizing the data that's been presented, the data that's been published on these non-invasive tests relative to a reasonable likelihood of predicting a clinical outcome. That data has never been synthesized and put pen to paper and published. And I feel like I have my own charge is to get that done as quickly as possible. That's one thing. The second thing is there are still clearly gaps that need to be further enforced with additional data. And my hope is that at EASL in 2023, so this coming June in Vienna, that we're presenting data on the phase 3 trials that have NITs as part of them, looking at change in histology over time, and where appropriate and where available, NITs to outcomes. So that would mean if we can mine the regenerate data, where we have some patients now on drug for 7 years, is there a possibility to mine that NIT data, not only for histopathology change, but also for outcomes, and not just liver-related outcomes, nephrology, cardiovascular as well, I think are really important. And then could we mine the Madrigal data, not only from NAFLD-1, but from Maestro NASH? And could we look at the Acaro data? The Harmony trial is done. Can we mine the NITs developed there to correlate with histopathology and have that? And I think with those big data sets and potentially nail NITs data, we could augment the work that's already been done and hopefully published by that time with additional data. And that would be, in my mind, the hope would be that would be enough to convince the FDA to consider an NIT. Now, the next step would be that companies would need to develop their phase 2B paired liver biopsy study with the primary endpoint not being histology, but being the NIT, just like Madrigal did in their phase 2, just like Poxel just reported out, where MRI-PDFF was the primary, key secondaries were histology. We do that again. It could be MRE, it could be ELF, it could be PRO-C3, it could be anything. It doesn't matter. Even MRI-PDFF. You show you met your primary endpoint, you link that to histopathologic change, and you propose that to the agency for Subpart H approval as the surrogate endpoint. That's how close I think we are.
So I'm thinking that 2 years ago, that sounded frighteningly close to the Holy Grail.
It is. You have to be careful which chalice you choose, but you're right.
Choose the wrong chalice, you get the lion, right?
Yes.
Or the bear. Louise, go ahead. Question, comment, thought?
I love all of that. And we've come a long way. And we commented with Donna in one of the sessions this week that where we were when obeticholic acid got turned down and how down we all felt at that stage about where we were going, to how well we feel and excited we feel about the next year coming. Two different ends of the spectrum, really. But just on evidence of NIT data, is this an opportunity for liver units per se to now get involved in some of that data? Because units like Imperial, King's, certainly in London, and these big units, they've been using FibroScan and the non-invasive technologies for a good 15 years now. Is there the opportunity to look at the serial improvement in those NITs in patients through liver care to see what the outcomes are there, to also enhance the data? Because that's real world. Those are out of a trial perspective, so they're the all-comer patient that doesn't necessarily always meet the strict criteria for trial inclusion. So mining that type of data could be done. Would that enhance or would that detract from proving the point of outcomes for non-invasive technologies with the FDA?
I think it could help, potentially, yeah. I'm not sure that would distract much from that.
So where would that, Louise, as you asked the question, or Stephen, where do you envision that fits into the scheme of what Stephen's talking about right now?
Well, I think we see and manage patients in real world based on their improving liver function tests for year on year on year. We've seen it post the cures and the SVRs for Hep C, in that we've monitored their FibroScans, we've monitored their liver function, genotype 3 particularly. We looked at their lipid profiles as they rose afterwards, and that was a concern afterwards in the real world that wasn't ever shown in some of the early clinical trials. So we discharge patients on that improvement. That's an outcome. They're improving. We've got data that shows that we improve their liver health, we monitor the non-invasive, their cardiac functions improve. So there is, in the real world liver unit data space, a lot of evidence that we don't biopsy patients post-treatment. We very rarely will biopsy somebody once they've got proven cirrhosis. In the real world, we do monitor with non-invasive technologies, MRI, CT. We don't have so much access to MRI PDFF, but I'm sure that could be gained. So using what we do in real practice as part of a submission to the FDA, because we're trying to prove the Holy Grail, which is not necessarily what we do in real practice. I wondered if mining that data, because we have hundreds of thousands of patients there. We did a very quick data registry during COVID. Lots of patients globally went on that to monitor for their COVID outcomes. And I'm not too sure how far Nimble, Litmus, Goldmine, and that cross those sort of boundaries into the real world evidence that could be gathered together on outcomes.
The way that, this is just my perception of the way drug development is done in the U.S., is that is more of a post-marketing commitment, phase 4 type trial or real world look at what's happening. But from a clinical trial perspective, you have to have defined endpoint assessments. And you're in a study, right? You sign a consent form, you enroll. I think the type of data that you're looking for just comes with thousands, if not millions, of cases where drug is being used and you're seeing real world changes in outcomes. I think that comes later. I don't think that helps get you Subpart H approval.
I suppose my question was, is the question, do we move beyond the biopsy? Because we can show that the use of multiple non-invasive outcomes do show clinical outcomes. That's a separate question to the clinical trial outcome. So it's moving this, just the question from the FDA about use of biopsy. Now, the use of biopsy currently in the NASH clinical trials, I totally understand. And yes, we would like to move that beyond the biopsy. But evidence about other non-invasive therapies and techniques being a useful marker and proven against clinical outcomes for patients, whether it's quality of life, whether or not it's discharge from care, whether or not it's improvement of cardiovascular function, that to me is a different question. That is purely the question, can a non-invasive technique be correlated with a clinical outcome? Yes, it can. We can gain that evidence.
Yeah, I think that's a payer question. The question I get asked all the time is, are payers going to mandate a liver biopsy to be put on therapy? Look, in real life, we don't do biopsies for NASH anymore. So I don't think the payer is going to mandate that we do liver biopsies for NASH. Not only that, but they're incredibly expensive to obtain. So that increases cost already. So this is just me speaking again, but I think we'll have non-invasive tests to qualify people for drug based on the data that you just mentioned. And that data exists today, by the way. So we'll be able to use, whether it's FAST or a certain FibroScan or a certain set of metabolic risk factors with FIB4, or, maybe we use the AASLD algorithm or the AGA algorithm or the ACE algorithm, which are quite similar in that you have FIB4 followed by FibroScan. And if you're in that camp of greater than 1.3 with a KPA greater than 12, and then maybe that's the group that gets treated. If your FIB4 is greater than 1.3 and you're indeterminate between a KPA of 8 and 12, you do additional testing. Maybe it's an ELF score, maybe it's an MRI. And if you meet those criteria, then you can establish treatment. But I think we're going to use NITs more from the payer perspective to decide who to treat in a different way than the way they'll be used, as you mentioned, with the FDA for drug approval.
So, Stephen, I want to come back to the drugs and the path that the drugs are on in a second, but I'm struck by this comment. What strikes me is that the third thing that goes on, right, is you put the drug in doctors' practices. And then a friend of mine used to say there are two trials that matter. One is the trial that gets you approved, and the second is the trial in every doctor's office on their first 5 patients. So I'm listening to Louise, and I'm asking myself how much benefit that has on that third trial, not just the payer, where I think you're right. I think they're not going to require NITs, but to what degree can we educate treaters on what they should be looking for in a way that relies on publication of that kind of data, and therefore gets them more comfortable faster in a broader patient population? Because ultimately, that's where a lot of the ramp-up curve is going to come from, I think.
To me, I think if you get a drug approved, people are going to want to use the drug, and they'll embrace whatever technology the payers are allowing you to use to make that diagnosis and to monitor response to therapy. So it becomes much easier, I think. It's a much easier story to have, a much easier discussion to have with providers, and for that matter, patients directly. It's more of an educational thing. What is a FibroScan? What is an ELF score? What is a FAST score? And to the patients, tell me again what NASH is. Tell me why I need to be treated with this drug, and if there's side effects linked to it, why do I want to take this drug where I have this chance of having an adverse event? I mean, those are, to me, the discussions that are going to be had. How long do I have to take the drug? What can I expect in taking this drug? As we develop the field, it's going to not just be so myopic that we talk about the liver. We're going to be saying you're taking this drug because it's not only helping your liver, it's helping your metabolic dysfunction. It's helping your glycemic control, your atherogenic lipids, your weight, that sort of thing. So, and oh, by the way, with that help, we're going to see changes in the tone of your vasculature. Stiffness is going to improve in your ventricles and in your aorta. Your GFR is going to improve. And ultimately, we think hopefully your risk for extrahepatic malignancy will go down. But those are things that come in the future. I mean, I think initially it's going to be teaching patients about the disease, teaching providers about the diagnostic options and the drug and how it works. And then the payers teaching them about what kind of magnitude of effect change with the NIT can be linked to clinical benefit relative to that particular mechanism.
That's great. And that makes a world of sense. I want to shift and spend a little bit of time with the drugs. I've been saying forever, and a couple of others, that the second drug is really in some ways the one that matters, because with one drug, the decision is whether, but the question becomes which on the second drug. And at that point, the assumption generally is people will treat. How likely, if you had a guess, is it you think we'll get to 2 drugs by the end of 23?
When you look at what the chance is to having 2 drugs approved in the next year, having 2 drugs approved in 23 is probably a bit of a stretch, just because at a minimum, let's just say a beta-cholic acid gets approved. That will happen in 2020. We'll know whether it's approved in 2023. With resmetirom, I'm not sure we necessarily, even if there's positive results, that we'll know it's approved in 2023. I mean, I'm just doing the math, 6 months to file an application. And even with fast track approval, the FDA has 6 months to render an opinion. So, maybe it's Q1 of 24. So I think in my wildest of possible scenarios, you have 2 drugs approved in 23. I think the reality is it's 0 or 1 with another 1 to follow soon after in the first quarter of 24. I think it's unlikely you have 2 approved in 23.
Given that the resmetirom data hasn't, that makes good sense, I think. I think that sounds like a much more rational calendar.
But one other interesting thing to talk about is how many drugs will be in phase 3 development in 23. Well, you'll have Lani, you'll have Sema, you should have efruxifermin for sure. You might have icosapent. It may not be out of the realm of possible to consider pegozafermin in phase 3. If it happens, it'll be late in 23. But I think for sure you'll have an FGF21, a pan-PPAR, a GLP-1, and maybe a structurally engineered fatty acid if there's a positive phase 2B result in Q1 with North Sea's compound.
Which I think, by the way, has a lot to do with why Big Pharma is starting to bring money in again, right? You see more things actually coming far enough down the pike that some of them are going to hit.
I mean, listen, I'm super excited to see Merck jumping in, AstraZeneca, GSK, Gilead's not giving up, Novo Nordisk, all kind of really saying they're in it to win it. That's great. fantastic. And I think that'll only be encouraged more if we can show that NASH is a druggable disease, right? That if we can get a drug across the threshold of FDA approval, I think the floodgates will open. And they may not open very wide, but I think they will be thrown open if we can get to the NIT part as a surrogate.
This has been a week of gifts for fatty liver disease, hey? Starting as it did Monday with the release of the resmetirom Maestro NASH 3 data and all the excitement that spread throughout the week. Ian, have you gotten to track much of that this week? And in conversations with colleagues, what are you hearing and what are people feeling about it?
So, yes, I have been able to track a lot of it. It was very exciting. And in many ways, I was away at a different trial steering committee meeting on Monday and was travelling back on Monday evening while you were recording the group conversation. And it's a real shame and disappointment to me to have missed that, because it really is a remarkable moment, I think, to see a drug meet both endpoints in a phase 3 trial in a way that I think is clinically meaningful for patients. And it's a milestone in the development of therapies in NASH. And I think it's one that we'll look back on, reflect on in the future as being something that really changes the way that we approach what we do. And that's been reflected in conversations that I've had here with colleagues about how we might need to think about our services to make them work better for patients who will need treatment and how we'll access that treatment. There's a lot of water to go under that bridge first, but being prepared now will make the most of the opportunity when it comes.
So could you elaborate on that a little bit? We've had lots of people talking about this with us, lots of different ways this week, but that's not a comment yet that's come up. So I'd love to just hear, I'm not even sure if that's what we're prepared to talk about, but I'd love to hear a little more about that.
We've currently got a service that looks after patients who've predominantly got advanced liver disease, whether that's F3 or cirrhosis. And patients who aren't in that more advanced group are largely being discharged back to primary care. So we need to think about how we organise our services locally so that we can access that population, if ultimately that is the population that's going to be appropriate for treatment, following the various reviews that will need to be in the UK, both regulatory and then from a cost effectiveness perspective with NICE. And then there are all of the other issues around interpretation of the results of the trial about the benefit to patients. All we've seen so far is the top line results, and whilst those are very welcome, I think we recognise, and I've talked on the podcast previously about the difference between the regulatory endpoints, which is regression of fibrosis, and the real impact on patients, which may come through stabilisation of disease and particularly through prevention of progression. And it'll be really important to see those types of data as they're presented and ultimately when the manuscript's published, because I think that the clinical benefit is different to what the regulatory endpoints say. And whilst I don't think that this drug or perhaps any of the others will be completely effective against NASH, I think that the patient-facing benefit might be greater than what's already been reported. And I think it's important to bear that in mind.
So that makes sense to me. Jörn, what do you think?
It's an interesting aspect because what Ian is implementing or hinting at is that there's a lot more to that disease than the change of categories on a fibrosis stage or NASH resolution under the microscope. And I'm full alignment with him here. It's very exciting to learn. We've seen some top-line results. There's a lot of it in it. I think the reason why I'm with you, Ian, and saying this, we're going to be looking back and saying this is going to really be a breakthrough, is we also have beneficial safety top-line data, what they revealed. And it seems that this could really move beyond what's been previously shown, because it's not the first trial to report a positive effect on fibrosis, but it's maybe the first one where we have both, and then also a more beneficial efficacy safety ratio. And the discussion is solely focused on getting the first drug across the finish line, which is the predefined FDA categories. But as you said, then all the other aspects come in: quality of life, changes in biomarkers. And I wonder how much we're going to be able to see, because it's, again, an ongoing trial. Can't risk deep blinding. It's a 5-year study looking at outcomes. And that will be quite a challenge moving forward, but it'll be interesting to learn how you implement that. And maybe we can also, I think as a field, we have to define how to implement that type of care. The next thing is maybe we can learn a little bit from the UK, because I think it's an obvious call that drug approval is going to be in the US, and Europe is sometimes perceived a little slower. For sure, we have more countries involved before a drug actually comes to market, and it might be that the UK is actually moving a little faster here this time. Maybe I'll learn from you, Ian, how you guys then use it once it'll become reality that we have a drug to prescribe.
I don't want to talk about any benefits of Brexit because I don't really truly believe that there are any, but the But having a different drug regulatory framework might mean that approvals could come quicker, though I doubt that. And the process of approval through NICE switches to show cost effectiveness is likely to be iterative, because what's happened previously with high cost drugs is that the companies come with a cost effectiveness model, and then everybody goes into a dark room with all the windows blinded and the door closed. A different price is established to bring it into a cost effectiveness level, and then they come out again with an approval. And that's never a quick process. In contrast to what happened when the DAAs first came online, where there were early access programs, the case for early access programs when you're not treating cirrhosis and patients are not at imminent risk of liver-related morbidity and mortality, I think is much harder to make. It's one that I expect that people will try to make, but I suspect in a UK, perhaps European perspective, that's going to be much more difficult. I don't know what you think about that, Jörn.
Yeah, I agree. I think there's going to be for sure more negotiation and talks required. And I mean, we're hypothesizing here on future outcomes. We'll have to see how the regulators view these results, and it'll be an interesting discussion in the first place. So while overly excited about the next steps, we of course got to take one at a time and see where it takes us.
Yes, agreeing with all that, and also agreeing, Ian, with your comment about early access programs. I think there's also something in the economics, which is that at the price per therapy or per patient of the DAAs and the immediacy of results, it was a lot more economically sensible to do whatever you had to do to get that drug into patients' hands immediately so you could start proving real-world experience. Here, somewhere between somewhat lower level of efficacy, I think I'd say 90 versus 30 are different levels of efficacy, and the fact that you could get results very quickly in measurable ways with DAAs in very sick patients, and here it's a little different. The public health case to be made for extensive early access probably isn't as strong either, and the motivation. So for all those reasons, I think that's accurate. On the other hand, NICE has kind of had a big month this month. As we've reported earlier in the month on the podcast, they seem to be at the end of making a decision to allow FibroScan to be used in primary care in the UK, which is a story we've been covering through the year because obviously it's of interest, I think, in general and specifically to Louise. But the first time we talked about this back in March, this was not a result that it looked like anybody was headed towards. How will that affect you and the practice of hepatology and the whole patient screening process it leads if, in fact, primary care has controlled but wider access to FibroScan?
So I think it's an interesting question. I think I've been on the podcast twice to talk about NICE and FibroScanning, and I was expecting my icebreaker to be what was my favourite moment of the podcast this year, and it was the second of the NICE discussions, which was held on Halloween, and Jörn came with a meat cleaver in his head to the podcast, and that's been the highlight of the recordings for this year for me. But in terms of access of primary care to testing, it's something that will be interesting to see how the uptake comes, and that will be around a case being made that testing is done better in primary care. And when I say better, I mean more efficiently and easier for patients, and that primary care are willing to take that workload on. So there is a recognition in primary care that liver disease is important and that they're seeing more of it and they're doing more testing. I'm involved in conversations with colleagues in primary care, not in Leeds, but across the UK, about how we might streamline or make testing for patients who've got risk factors for fatty liver easier, to take out some of the intermediary steps and allow those patients to have a fibrosis assessment more quickly. And that will definitely be made easier by having the availability of machines and trained staff in primary care to deliver those tests with appropriate decision support from specialists or from other providers. That will definitely help. The other thing that's happening in the UK is that there is a central research funder call out at the moment for studies in early diagnosis, and I expect that will involve it calls for fibrosis testing being made available in primary care. So I think there are several routes through which FibroScan will become, and potentially other tests will become more available in primary care over the course of the next couple of years. And it would certainly help us in secondary care, because that would be one less thing that we would have to do to optimise our referral pathways and to manage the flow of patients from primary care into our services.
Interesting stuff. A lot of progress on a lot of different fronts. So, Ian, two thoughts. Number one is, if we want to have a visual image of Jörn in 2022 to leave our listeners with, I'm going to run around to the Mazen Noureddin side of the table, and I'm going to remind everybody that Mazen has nicknamed, and some of us have bought into the idea that Jörn's nickname should be Matt Damon. Thinking of Jörn visualized as Matt Damon might be a little bit more compelling than with the meat cleaver in his head.
I've never seen Jörn and Matt Damon in the same room at the same time, so we'd never know.
Now you got me.
So now we have the talented Professor Ripley, huh? So aside from meat cleaver, when you look back on 2022, What are the moments in either what you've learned or what you've seen or both that stand out most to you?
Well, so I think if you'd asked me that question last week, I would probably have said something about the increasing recognition that non-invasive tests are associated with prognosis and the pathways that will give us into the use of non-invasive tests for the stratification of patients for clinical follow-up and for treatment using a more risk-based approach. And I think that would have been what I would have said, I think. But obviously, this last week's changed everything, because I think even the top-line reports of a phase 3 trial that reports improvements in both resolution of NASH and improvements in fibrosis, I think it's the standout event of the year. And we just have to see how that progresses during 2023, but it really opens up lots and lots of potential opportunities as time goes on. And I think that inevitably has to take precedence over the other findings. Whilst they're very important, I think the trial is the standout event.
So then, I think we all agree. Then I'm going to ask you to go back a week. So it's an interesting thing. You know, you came on last summer when we talked about what we thought were the big events of the year. I think that was this past summer. It could have been 21, but I think it was 22. And you talked about ELF and the approval of ELF and the importance of that. I was noting recently that in the States, at least, LabCorp will now reflex you an ELF result if they run a FIB4 off data that's an electronic medical record and identify FIB4 high. They'll just reflex ELF immediately if in fact the institution allows that, thereby taking one more efficient step towards the process, at least in the States, of identifying patients who are at significant risk quickly, which I think was the kind of thing you were talking about then, actually.
I'm all for efficient pathways to identify patients at risk of significant liver disease, whether that's NASH or whether it's alcohol-related liver disease or even viral hepatitis. And I've said it before and I'll say it again, we have to make the pathways as straightforward and easy to use as possible, regardless of liver disease, and ideally using the same pathway and the same tests to allow primary care and other hospital specialties to identify those patients who need to see a hepatologist who would be suitable potentially for a specific therapy or other intervention that can be provided. And what I was saying before about the relationship between those tests and prognosis becomes more important, I think, because it's much easier to say to somebody that this patient's at risk of these events than it is to say their test's high, we need to see them, because it's more meaningful. You're saying something that matters to the clinician who's otherwise looking after the patient. You know, there's a risk that this patient will develop cirrhosis or will have liver cancer or will have a decompensation event at a meaningful rate, whether that's 1 in 50 a year or 1 in 20 or perhaps higher if it's an unrecognized patient with cirrhosis. So those types of mechanisms are helpful, I think, in prioritizing patients to get into hepatology care. The other thing that they're useful for on the other side is to make sure that where liver disease is relatively less important and where it isn't a primary focus for that, or shouldn't be a primary focus for that patient, that those individuals are recognized at low risk and that testing stops, so they don't end up in the endless cycle of liver blood tests and screening and ultrasounds and stuff that they don't need. Because actually, if we can focus on those patients who are at greatest need, we'll get more positive feedback from those communities. You know, we'll identify the people at risk. It'll be clear to the referrers that those people are at risk, and they'll be able to focus on those. And we need to provide them with better tools. And one of the other things that's happened during this year is the validation of various scores as it has been done, whether that's MRI-based scores or the agile FibroScan-based scores. You know, the non-invasive test environment has matured. The pooled analyses from the Litmus Consortium have been published at the end of last year and through this year. So the quality and the impact of that data is improving all of the time. And the challenge now is to either to settle on scores and say, we think this is the best combination, this is what we should all use, because that'll help to standardize practice and make decision making for people easier. Or we say that we really don't know and we need lots more biomarker discovery. Now, I think I know where I stand on that. I suspect that we've got tools that for the uses that we need are going to be as good as they're going to get without lots and lots of costly intervention. But we need to see what's going to happen. I can see Jörn might be nodding at me or disagreeing. I'm not quite sure, but I'm sure that he's got a view on this.
I'm agreed, Ian. I think we have the tools we want. They're widely available and fairly cheap, and we can implement them. So when you were starting to talk, I was actually picturing like a traffic light system in my head, because I have these patients that come back every 6 months for an elevated GGT with no fibrosis, and they are not accepting that there is no liver disease risk for them, and they bother their primary care on that test to be resent to us. And then I show up and I go like, oh, I told you last time that you shouldn't show up again. So these type of referrals, of course, are the ones that you would want to give the reassurance based on the data we're generating, based on NITs, no need for referral. And I think NICE is a little better and channeling that, but I would want to implement that for my practice in more stringency to be able to use and look at the ones that have a different traffic light signal and that are at risk of developing endpoints. And for that, for sure, there is more potential in biomarker development. And, we're doing a lot of scientific work around that. But I think we have the tools we need now to risk stratify, and we can move forward based on that. I'm aligned with you on this.
Yeah, I think that makes three of us, actually. Not that there isn't room for improvement or need for improvement, but these are probably not the things that need the most improvement the fastest. And number one. And number two is one of the things that's happened this week, not surprisingly, with the publication of the Master NASH results, is that stock prices have gone up. And not just for Madrigal, okay, but for other companies with innovative products, Akero, Altimmune, just to name two. Some of that's about predicted M&A activity, but what that speaks to is the idea, I think I've been saying this all along, is that, and I'm not the only one, that one of the benefits of a positive trial is that money would flow in, and that even if money that comes in through pharma is not a completely unbiased educational tool, it is an educational tool in a place where we've got precious little education going out to lots of groups that need it. So I'm wondering where you believe, or where, Ian, in your practice and Jörn as well, if more money comes into the field through improved stock prices and investments, and big pharma deciding that it's now de-risked enough that they want to come into the game, how will that affect anything that you do today in a way that's tangible over, say, the next 2 to 3 years?
Well, the two biggest things I think would be disease awareness, because as soon as there's a marketed drug or interest from big pharma, there'll be education. I say that loosely, I mean advertising really, but education to hepatology, to related specialties, and probably also to primary care to some extent. So driving disease awareness, diagnosis, and patients coming through for treatment, probably not in the next year, but depending on what happens commercially and from a regulatory perspective, probably slightly later than that, but I'm sure that we'll see that. The other thing that I sort of hope is that, having had success in one form of steatohepatitis, we might see increased interest in alcohol-related liver disease to parallel that's going on in NASH. And I know that this podcast is focused on non-alcoholic steatohepatitis, but was on the ward recently, and it's fair to say that the ward is not full of people who've got decompensated non-alcohol-related liver disease. It is by far and away alcohol-related liver disease that is still dominating our inpatient practice, and in many ways that's where we have the greatest need for intervention to try and diagnose those patients earlier, which is why I said a shared pathway for patients with disease being identified, but also treatments to try and prevent the devastating outcomes that we see in those patients, many of whom are often young with families, and that I would really hope that we could or might see increased investment in that area too.
That's interesting. And I'm not sure I know how that dynamic works, because I think investment tends to follow proven patterns. It's always easier to get. So, for example, one of the questions we talked about earlier in the week was, if you had other THR betas in development right now, it would be easy to get investment on that. Easier than to get investments on modes of action that are unknown, because fundamentally what Madrigal just did was de-risk the mode of action. So you then have to take that over a disease, and you have to find a pathway for alcohol per se that's sufficiently de-risked that people want to spend money on it. And I think, given that we still don't have a successful cirrhosis trial, that may be a while coming. I hope it will evolve the way you just described, because that's clearly where the need is. But there may be a couple of steps left on that path, I would guess.
Yeah, I'm sure you're right.
On the other hand, somewhere in the middle, to the degree that we can do a better job of identifying and treating patients whose problems are both, if you will, the famous acronym BAFFLed, which I guess is going to go away as soon as we solve the rest of the nomenclature question. I would think for BAFFLed patients, we might, if we solve the nomenclature question, or whatever, the solve is probably the wrong verb. I think resolve is probably the right word. There will be some resolution. It will not be a solution. It will be a resolution. Whatever resolution comes from that, my guess is BAFFLed might go away, but those patients might be easier to target and identify now, one would hope.
So, and I agree with Ian that alcoholic also in my region is a big thing. The second aspect these alcoholic patients have is, of course, the addiction, which is not to the same extent happening in the non-alcoholic fatty liver disease. However, I do see a subset of alcoholic patients that are really surprised by the time they hit cirrhosis, they stop drinking and regress, and they're not as much I think their risk of falling back to behavior, which we're seeing with NAFLD and, nutrition, lifestyle choices, is maybe a little less obvious. But then again, alcohol is the stronger toxin. It leads to more severe disease earlier. It's clearly a different class of patients.
Agreed. Conversely, one can live without alcohol. One cannot live without food, which means that every day there's a automatic temptation, at least twice a day, to be tugged back to the bad eating habits. Whereas if you can figure out your behavioral triggers, you might be able to, and you're motivated, you might be able to stay out of alcohol. I struggle with sugar every day of my life, and I could give up alcohol if I had to, but I don't know that I could successfully give up sugar, given that I eat food 2-3 times a day, and foods tend to have sugar in it. So Ian, on top of all that, what are you working on in Leeds this year that you'd like to share with our listeners?
Well, the focus for 2020, or one of the focuses for 2023, is that our funding agency is going to run a specific call for studies in liver disease in 2024. And in preparation for that, they have launched 15 liver disease partnerships, and we're hosting 2 of those in Leeds. So we're going to spend a lot of next year doing preparatory work for funding applications in 2024. And the call from the agency is really around disease prevention and reaching groups that have previously had very little engagement in research, and that is specific communities, not around the big teaching hospitals, but more in the districts, and particularly around coastal areas which are deprived and have high rates of obesity, diabetes and alcohol use. So we are going to work on engaging those populations, defining questions that those patients want answering from a research perspective, and doing a lot of work with other stakeholders across the whole of the spectrum, from primary care, from mental health and addiction services, into secondary care, liver disease, diabetes, obesity, and other related specialties. So it's going to be a busy year of workshops and talking to patients and stakeholders and bringing together all of the right people so that we can write compelling bids for funding to do studies that will impact patients down the line.
Next week, we start our coverage with a rebroadcast of Stephen Harrison's NASH Preview Wednesday, coupled with comments from some of our friends about what they anticipate most about the meeting. On Saturday and Sunday mornings, we will record reviews of the previous day's sessions, which you should receive around 6 p.m. Eastern U.S. Standard Time each evening. Finally, we will record our summary episode on Monday, January 9th, and post it on Wednesday, January 11th. On behalf of the entire NASH Tsunami team, we wish you a healthy, rewarding, and productive 2023. As Roger says, stay safe, surf on, and we look forward to seeing you again on the Surfing the NASH Tsunami podcast. Have any questions for the surfers? You can send them to surfingnash.com, and we will answer on the podcast or the website.